The best scar treatment is not the most expensive tool. It is the tool matched to the problem the scar actually has.
Wait, so a laser isn't always the best option? Because, as a patient, it is just so easy to assume that the newest, most expensive technology out there absolutely must be the universal fix for any scar. That is a super common assumption, but actually, no. And before we get into exactly why, this explainer was written and edited by Dr. Thomas Hocker, a triple board-certified Harvard and Mayo Clinic-trained dermatologist, Mohs surgeon, and dermatopathologist. The very first thing the clinical evidence tells us here is that there's no medically honest universal league table for scars. You literally cannot just rank silicone versus laser versus surgery without first identifying the specific problem we're dealing with.
Let's dive into this using a visual that honestly brilliantly illustrates the point. Picture a master luthier tuning a gorgeous cello. If a string is out of tune, well, they adjust the tension peg. If the bridge is too high, they carve the wood. They would never ever use a hammer to adjust a string's tone, right? In medicine, a clinician is doing the exact same thing. We have to map each specific tool to one distinct scar phenotype, and we have this imaginary timing dial we've got to watch carefully. You just cannot use a single generic tool to fix every unique scar problem.
So, what does this all mean for you? It means there's a strict decision sequence required before any cosmetic tool ever touches the skin. Step 1, you confirm the wound is completely stable. Step 2, name the dominant feature. Is it red, raised, or depressed? Step 3, choose the least burdensome tool to fix that specific feature. And step 4, measure the result before you ever even think about adding another treatment.
And that brings us right to Rule 1, which, absolutely no exceptions, can never be skipped. Cancer control and wound stability have to come first. Before applying any cosmetic tool, we must be 100% sure the wound isn't actually a recurrent tumor, a stitch reaction, a local infection, or a keloid. Why? Because those all require vastly different care. But once we know the diagnosis is a normal early linear scar, which we call phenotype 1, what comes next?
Right. So what am I actually supposed to do for a brand new, completely normal looking line right after the stitches come out?
Believe it or not, immediate procedural escalation is almost always a mistake here. As you'll see, a normal early line usually just needs time, strict ultraviolet protection, consistent photographs to track progress, and sometimes selective tension support, like tape. Throwing aggressive treatments at a scar that's already healing in the right direction often just adds irritation. We definitely do not want that. Now, once the surface is fully healed, if your clinician identifies that the scar is at risk of becoming raised, well, that's when we look at the evidence for topical treatments. And the strongest first-line evidence isn't for just any generic, heavily marketed scar cream you see on TV. The evidence-backed choice is actually silicone gel or sheeting. It offers a modest but clinically proven benefit in preventing that raised tissue. Let's look at this comparison grid and see how this builds, because this is where that luthier metaphor really clicks into place. Look at the difference between a red vascular scar and a raised firm scar. If the dominant problem is persistent redness, a planned vascular laser course is the right instrument. But listen, a vascular laser will never flatten a thick raised keloid. For a raised scar, the tool might be an intralesional corticosteroid injection or silicone. But be super careful here. Injections can actually thin the skin or alter pigment, which is exactly why matching the tool to the phenotype is absolutely crucial. Okay, let's pause right here. So if there's absolutely no universal best treatment and everything completely depends on the exact phenotype, how on earth do we cut through all the marketing noise out there and, measure reality? That is exactly why we ground this whole discussion in the evidence. Let's look at the actual numbers. 375. That's the number of patients across 6 randomized trials that proved silicone's modest effectiveness for improving postoperative scar height and pliability. That is real, replicated data you can trust for that specific phenotype. And here's another one, 52. Out of 76 randomized surgical patients, the 52 who actually completed a 3-session combined laser protocol proved that a carefully planned series works for selected surgical scars. But here's the catch. A separate 20-patient trial showed that just doing one generic single PDL laser pulse right at suture removal does absolutely nothing. A planned course aimed at a specific vascular target is entirely different from a single generic zap. What about natural options, though? Isn't vitamin E a better, safer first step to just rub on a scar?
Oh, man, we really need to look at the numbers before assuming natural automatically means safe. In a small, double-blind trial of 15 patients, topical vitamin E provided literally zero cosmetic benefit, but it caused contact dermatitis in 5 out of those 15 patients. To put that into perspective, that's a 33% reaction rate. We firmly have to follow the data over what simply sounds familiar.
Now let's look at 2 completely different instruments we might need to tune. If tissue volume is actually missing or bound down, like a depressed or tethered scar, a redness laser won't fix it. It just won't. You need geometry-specific tools like fractional resurfacing, subcision to release the tether, or fillers. On the flip side, we have pigmentary scars. This requires diagnosing whether the pigment is darker or lighter than your natural skin and planning around your specific skin type. Once again, an instrument that improves redness will never, ever restore missing pigment.
So are there times when a patient absolutely shouldn't wait for things to heal, like skip the cosmetic timeline entirely?
Yes. Urgently, yes. If a scar is causing functional distortion, meaning it's physically pulling an eyelid down, narrowing a nostril, displacing a lip, twisting an ear, or restricting a joint, you do not wait for a 1-year cosmetic maturation deadline. Function cannot wait. This demands an early surgical assessment.
And if surgical revision is the chosen route, it is vital to understand what that actually means. Surgical revision replaces one scar with a new scar. It completely dispels the myth of total scar erasure. The goal is to rebuild and redirect the tissue for a better functional or aesthetic result. But make no mistake, you are trading one scar for another and starting the healing clock all over again. So let's circle back to our opening point. The best scar treatment is the one that matches the scar's dominant problem and timing. Think of that master luthier again. Excellent, beautiful results don't come from hitting a cello with the most expensive hammer you can find. They come from precise, phenotype-matched tuning over time with the exact right tool. Wow, this has been incredibly helpful and practical. For anyone watching, your next steps are to read the complete evidence guide on Skin Trust and then have a highly targeted conversation with your treating clinician about your specific scar phenotype. And be sure to join us next time as we answer another critical Skin Trust question. Is Mohs surgery actually necessary for every single skin cancer? Dr. Hocker created Skin Trust to provide free, evidence-based dermatology education and help patients and clinicians make clear decisions together. If advanced lasers aren't a magical eraser, it really makes you wonder, what other expensive dermatology myths are you paying for? Thank you for joining us on this explainer, and we'll see you next time.